Okay, as was scheduled, shall we begin session 2? And session two's theme is Japan's long-term care viewed from Asia. And so during the break, and we have received some questions. And so after the part 2 of the session, and we're going to have some brief this break time. So during that time, you will have another opportunity to punch in your questions and send it through the chat, so we can receive your questions through the chat. First, so let me introduce to you and call upon the next speakers, Ms. Duan Nugami and Ms. Gwenty Langwon from the College of Care Work of the Syrian Christopher University. And the ladies, the floor is yours. Okay, so I'd like to share the screen with you. And good afternoon, everyone. And I am Duan Nugami, an international student at Syrian Christopher's University College of Care Work. And I'm also from the same college. I am Gwenty Lanhon. We came to Japan after graduating from the Faculty of Nursing at Suitan University in Da Nang, Vietnam. While we were studying at a Japanese language school and working part-time at a nursing home, we worked with Dr. Hiruma to translate Professor Higashijima's book into Vietnamese. Today, we'd like to talk about some of the differences we noticed between Japan and Vietnam through translation. And now, so we'd like to begin. And so these are the contents of our presentation. The first item of the content is some Japanese words that are not in Japanese. Secondly, what are the things that will be useful in Vietnam? And thirdly, what are surprising things when we worked part-time at a nursing home? And what was in the background? And finally, we'll make suggestions for skills transfer in oral care to Vietnam. So first, there were some words that are not in Vietnam. No, there were 3 words that are not in Vietnam. So there are assistive tools names such as all-purpose cuff and grip and the word thickeners. So although these are common in Japan, but they are not commonly used in Vietnam. The second is some anatomical terms. So unlike tools, most anatomical terms are also found in Vietnamese, except for 2 names of muscles around the throat. So these 2 words, the Japanese anatomical terms, and so we're still looking at for the Japanese words for them. The third is onomatopoeia, like a pa, ta, ka, la, should remain pa, ta, ka, la in Vietnamese, because it's one of the oral exercise, a way to train the muscles needed to eating by pronouncing pa, ta, ka, la. So by doing this, the elderly can train the muscles needed for eating food. So on the other hand, onomatopoeia such as gara gara or goro goro, go hon, and ah, they are expressions unique to Japanese, but of course we need to translate them into Vietnamese. And next, what are things that might be immediately useful in Vietnam? So we think there are 2 things in particular. So one is nutritional supplements, because in Vietnam, elderly people with impaired swallowing function are just eating porridge or just drinking water or milk. Since there's no soft food such as jelly, so they immediately turn to porridge, and this is accepted as inevitable in Vietnam. So as a result, the nutritional balance of the elderly is not very good. So nutritional supplements would be a good idea. Secondly, and oral exercises and the finger joint exercises before having meals. And so of course, many elderly people do not like to wear dentures, but if they do not have teeth, they pay less attention to oral care. So therefore, so it would be a good idea to play games to exercise their mouth and maintain muscle strength. And so there were two things that surprised us during our part-time job at a nursing home. The first was assistive tools and equipment such as spoons, cups, etc. in a variety of forms to suit each person's oral condition. If we didn't have them, it would be very difficult for the care receivers to eat. The same goes for wheelchairs. And for example, a care receiver with a hunched back. So we found that she can eat safely with a good posture because of the cushions, the brakes on the wheelchair because she tends to fall forward, and the foot supports that are tailored to the condition of the user's feet. And the second is for the elderly people to eat ice cream. So one female care receiver eats as many as 5 servings of ice cream every day. In Professor Higashijima's book, there is a description that surprisingly elderly people like cold food. So we were not quite sure if it is all right to translate this into Vietnamese. And now it is my turn. Well, this is because in Vietnam, the elderly is considered to have lower body temperature and need to eat warm food. So that's because that's why they do not really eat ice cream in Vietnam. On a hot day, Vietnamese elderly people eat watermelon or mandarin oranges, drink water or fresh fruit juice. So behind the perception of ice cream is the food culture of Vietnam. And this is one of the modern, the Vietnamese folk taxonomy on food. Here is a quote from this book. There are 4 categories of food: cold, cool, neutral, and hot. For the elderly, ice cream is not good because it is in the cold category. And watermelon is all right because it is in the cool category, like melon. Furthermore, I believe that traditional medicine is behind this classification. In fact, when we read textbooks of Vietnamese traditional medicine and talk to doctors of traditional medicine, they confirmed that cold foods like ice cream have a negative effect on the stomachs of the elderly. Next, why were we surprised at the variety of assistive tools and equipment? So one reason is the difference in thinking and social systems. In Vietnam, the family plays a major role in taking care of the elderly. For this reason, even in having a meal, the elderly tend to receive full assistance. There are other rational reasons as well. For example, elderly people's hands often shake, so their family want to prevent them from getting dirty when they eat. And it is believed that the more food the elderly eat, the better, so they tend to receive full assistance. On the other hand, if a family member does not provide meal assistance, it is considered as neglect of filial duty. In Japan, on the other hand, it is considered important to make the most of people's remaining abilities. For this reason, we ask care receivers to do what they can do on their own and provide support for what they can do, what they cannot do. For example, for care receivers with hemiplegia on the right side, we use specially designed spoons and tableware that allow them to eat with their left hand. Lastly, we have a suggestion for the transfer of skills in oral care to Vietnam. So we think the study session among staff, as stated in Professor Higashijima's book, is very good. In particular, we think that oral care for dementia patients will be a great learning experience. However, if we hadn't had the experience of working part-time in a nursing home in Japan, we wouldn't have been able to understand much of the content of this book. Therefore, for skills transfer, we think it is necessary to do practical training after showing them how to do it, like the training often done in Vietnam. Also, we think it would be better to have study sessions not only for care and rehabilitation staff, but also for university, nursing faculty, rehabilitation faculty, and other specialists. Therefore, we would like to start with a study session on basic theories and knowledge using a Vietnamese translation of the book. Thank you very much for your kind attention.
Thank you very much. Now, I would like to invite Mr. Masayuki Tsuchihashi from the Anyang International Corporation. Mr. Tsuchihashi will present in the video footage, but he's already participating on the call. So your questions directed to him is also acceptable. You can ask questions to Mr. Tsuchihashi as well. Mr. Tsuchihashi, the floor is yours. Good afternoon, everyone. I'm Tsuchihashi and a care worker in the Shanghai International Corporation in Vietnam. Today, I would like to talk about the what is needed in the development of the care industry in Japan and Vietnam based on my experience working in this country. I'd like to share my screen. So I would like to briefly introduce myself. I'm Masayuki Tsuchihashi, a care worker. After graduation, I worked in the world of the TV commercials. After that, I worked at a care home in Setagaya Ward in Tokyo for about 8 years. And then I spent a year as a paid volunteer at a facility for the disabled in UK. Then I traveled all over the world to visit nursing homes and care homes. And now I am actually taking care of the Vietnamese elderly people at the Nhang Ai nursing home in Vietnam. My current duties include educating the staff about the elderly care and improving the facility. Nyang Ai also has a Japanese language school for the Kaigo technical intern trainees who are going to Japan. So I also teach them there as well. This is a fee-based care home in Tokyo, so where I worked. This is a photo taken when I was a live-in paid volunteer at a facility for the disabled in UK for a year. Since the theme of this event is eating and swallowing, so I want to show a picture of a meal in England. In UK, meals are very simple and the menu doesn't change every day for a month like it does in Japan. The menu is kind of fixed. Fish and chips on Fridays and English breakfast served on Saturdays and Sunday roast on Sundays. I wondered how they never got bored. So for those who could not swallow well, as you can see on the left side, the mashed potatoes, fish mash, and vegetable mash were served. So I thought it's a bit rough. So in this respect, I was very impressed by the level of the attention paid to the food by Japanese people, as far as I remember. Here is a shot of the Nyang Eye Care Home where I am currently working. There's about 100 beds and 40 for the bedridden students and 60 beds are non-bedridden patients. Oh, excuse me, the residents. Now, this is a scene from the Nyang Eye Care Japanese language school. I'm teaching both the cares and the Japanese language. This is a picture of the students we dispatched. We have dispatched about 70 students so far. I'm really looking forward to doing something with these kids in the future. Last year, I started to try a crowdfunding project to send care equipment to Vietnam because the inappropriate equipment restricts care workers from providing the kind of care they want to. This is temporarily on hold due to the pandemic, but will resume as soon as COVID-19 is under control. And we regularly hold an event called Kaigo Cafe Connecting the World in Hanoi for people in the medical and care circles in Hanoi. Though this is a corona situation in Vietnam briefly. Due to the Delta strain, there are 5,000 or 6,000 new cases been reported per day. I'm living in Hanoi, the northern part of Vietnam. There are only 50 cases are reported per day, but due to the explosive expansion of the infection in south, the control is very severe and strict. And when you go to supermarket, I have to show my certificate or the approval to go. And since the last month, so and I'm working, or the other staff members are working, stay in for a month within the facilities without leaving the facility due to the restrictions. And this is a look at the Nyang Ai Nursing Home. We have many mango trees, and the facilities has a large garden and it is open facility. And the mango bears fruit 3 times a year. And there is a yellow mangoes and blue mangoes, and we can distribute the whatever mangoes according to the favorites of the residents. And there are many religious events, national events, and war victory celebrations. So, which I found very interesting. In Vietnam, people have a strong image of these facilities as shelters. I've been a care worker for the past 3 years, and I've been telling that it's not a shelter, it's not a place to pity or give anything. I try to make improvements while telling them that this is a place for living and the embracing the dignities of the people. For example, we have done the improvement of the living environment, such as railing in the rooms and the passages. And we also improved the bathing environment too. And the left side is just before, when I just arrived. So only the shower, but we installed the hand rays that they can wash themselves by themselves. So we referred to the facilities in Japan and to get inspiration. When I first came, they were just watching TV all the time. But now, we started to asking the people to have a role in their daily life so that those who can do things every day can do them. This is them folding towels and making artwork. This is them helping with the daily cooking. You see the fruits and the vegetables I've never seen in Japan. So all the ladies cutting the garlics and small onions, so they are better at cutting vegetables than I. And the male residents are sometimes asked to do things like pruning or washing the cars. So it's a bit hot in the weather is hot. So when it's cooled down, we ask them to do so. So I often asked in many occasions that what are the cares of Japan? How different from Vietnamese? So today, I would like to talk about the what I feel lately, which is a lifestyle model and a medical model. Vietnam is now faced with a rapidly aging population and low birth rate, and in urban areas in particular, nuclear families are increasing. Therefore, the demand for the care for the elderly is growing significantly. However, many people in Vietnam think that the elderly care is something that should be done by family members, and that long-term care facilities are only for the people who have no relatives to turn to or rely on, and the elderly care is something that anyone can do without any expertise. Another point is that in Vietnam, there is not so much distinction between nursing and the elderly care. There's going to be a discussion that's going to split these two concepts. But currently, the qualified nurses are basically doing nursing care. Even in nursing schools, classes on elderly care are given only for about 10 credits, and the actual work is learned through the OJT after they are assigned to the care facilities. In fact, many nurses in Vietnam also feel that the elderly care is something that should be done by family members or helpers. So when they work at a care home for the first time, many staff members actually feel at a loss that the job is different from what they expected, and then many people quit. This diagram shows the differences between the care model and the medical model in Japan. There are many differences between Japan and Vietnam in many aspects. What I have been feeling lately in considering other facilities in Vietnam is the difference in the way of thinking about the lifestyle model and the medical model. In Vietnam, I feel the nurses who have received a medical nursing education are still in the process of searching for a living model unique for Vietnamese people based on the medical model, but with limited service costs. So they are in the middle of developing or coming up with these ideas. Of course, it is the same situation in Japan, but what is typical in Vietnam is that the costs, needs, and available budget and what can be done, what is required will change over the time depending on the aging rate, degree of economic growth, among other factors. I think they are exploring at the moment of this time. So in this context, how can they create a lifestyle model that is unique to Vietnam? So in this respect, I feel that there is a need to learn from Japanese elderly care. So when it comes to the medical matters, the nurses have applied and also experience in their medical practices, and there are lack of the sources and the materials. They are struggling to deal with this situation. So now, next is meal and oral swallowing care. This is a meal situation. In Vietnam, the staple food is rice. Rice is also eaten, but rice is often made into noodles. In the morning, they eat pho, meat burns, and French bread for breakfast. The left side, this is a picture taken I have just arrived 3 years ago, and the right is a recent menu. The appearance and the nutritional contents have improved, and the special menu are now served regularly. I myself find the food at the care home very delicious, but on the other hand, however, I also work in the school part. The meals at the school became more frugal due to the rising prices of the meat and vegetables. So we want to improve this eating environment as well. In the beginning, the chairs and the desks were folded type and unstable. So the people were just eating while crouching. So we referred to the example of Japan, and we replaced them with stable desks and let them sit in proper chairs instead of the wheelchair so that they can eat with improved posture. As for the form of the food, there are regular meals, bite-sized meals, chopped meals, porridge, harusame or starched noodle, and blender processed meals. We don't have pouches like in Japan, but we make blended meals in the kitchen and serve them for those on tube feedings. In Japan, chopped food is not currently recommended as it is not suitable for swallowing function. But if it is eaten with thickener. In Vietnam, however, people eat their food in chunks or mixed with soup. If it makes you chokes over, then you have no choice but to switch to the blender food. So the blender food is also thick and sludgy though, so it looks hard to swallow. So I hope that we can arrange the food format according to the needs. I often feel that in Japan there should be more appropriate ways, so I would like to cooperate with the Japanese experts to improve these points. But I'm struggling in making progress due to the impact of the pandemic. For this swallowing, I would say the Kaigo or care in Vietnam is the different approach. In Japan, there are speech therapists and people who evaluate swallowing, among other things, but in Vietnam, there are no such people. So if a care receiver does not eat, nasal feeding is applied at a larger, earlier stage. I think this is partly because the only nurses make decisions on this matter. Whereas in Japan, I think there would be more multidisciplinary discussions ongoing to find a better way to allow the elderly to fully utilize their remaining physical function in chewing and swallowing with a full attention given by care workers to prevent any risk involved. For example, they would try to devise a new food form, or they might collectively come up with an idea that the elderly would eat their favorite food like this and looking into their life history. On the contrary, in Vietnam, when their swallowing condition takes a turn for the worse, they are immediately given nasal feeding, which is a way to avoid swallowing disorder altogether. I observe that the 0 or 100 approach is playing a role in such a decision making without leaving any possible options in between as part of the phased approach. Of course, things are done creatively in Vietnam too, but compared to Japan, they are very quick to make decisions. Unfortunately, once an elderly switches to nasal feeding, it is difficult to stop and go back. Furthermore, if the elderly are physically restrained to prevent them from removing tubes by themselves, the dementia may progress rapidly. In that respect, I believe that Japan's approach to food is best in the world. So drawing on that, I want to improve the situation so that we can have options in the middle rather than 0 or 100. Normally, I would like to get on with this task speedily, but it is difficult to make progress because of the COVID situation. We make progress and we go backwards. So I'm afraid that this 0 or 100 approach is applied in the decision making on aid equipment and toileting assistances as well. So I hope we can have more options to select from. In the meantime, Morinaga Vietnam contacted me the other day and gave us thickening agent, which is hard to find in Vietnam. It's very precious. The schedule was postponed due to COVID, but as soon as things settle down, we will hold a workshop with Japanese nutritionists living in Ho Chi Minh City on how to use the thickener and explore the posture to prevent aspiration. In Vietnam, the use of thickening agent is not yet prevalent. Nestles, the entered into the market 3 years ago, followed by Morinaga last year. With that thickening agent, the elderly could choke over regular meals more easily, so we make and feed a lot of mango or banana juice for them to drink. In the past, there was a resident whose swallowing was not good, and she was on the verge of nasal feeding. So because she choked when she ate chunks of food or branded food, her family really wanted her to eat by mouth, so they came over every day and brought her banana juice or mango juice. They devoted themselves to doing it. For example, if we had a thickening agent, it would have been easier for the staff to provide appropriate fluids. And Morinaga Vietnam is also planning to develop high-calorie drinks for the elderly in Asia. Not all of these products will be available immediately, but I hope that those who can benefit from any of them will be able to use these products and have a variety of options. And finally, I believe that in the future, there will be a variety of human resources in the field of the nursing and long-term care, including those who will go to Japan and will return from Japan, as well as those who, like me, will leave Japan. There is a lot of potential for a variety of services. New services will be created in such situation. So personally, I would like to get out of the cliched phase of, oh, I learned a lot by exchanging opinions. And I want to become a craftsman who can give shape to what is needed one by one through field practice, through the multidisciplinary networking. Thank you very much for your attention. This concludes my presentation.
Well, thank you very much, Mr. Tsuchihashi. Next, I would like to call upon the next presenter, Mr. Junichi Jakfukui, the CEO of Meganote Global Corp. And he's going to talk to us through a video presentation. And he's also with us for this webinar. And during the Q&A session, you may be able to direct your questions to him. And Mr. Fukui, the screen is yours. And now I would like to talk about the caregiving training and oral care in the Philippines. I am Junichi Jakfukui, the CEO of Maganote Global Corporation. Let me briefly introduce myself. I graduated from Japan College of Social Work and I became certified as a social worker and mental health social worker. After that, I worked as a caregiver at an elderly care home for Japanese Americans in the United States. After returning to Japan, I worked at several elderly care homes and obtained my certification as a care worker. Then, 10 years ago in 2011, I moved to the Philippines and have been engaged in the training of Filipino caregivers. Last year, I passed the Dementia Care Specialist examination held by the Filipino branch of the International Federation for Dementia Care and became a dementia care expert. Currently, I am working on the training of caregivers who plan to come to Japan and expand in Japanese dementia care in Asia. Well, in my private life, excuse me, and this is related to today's themes, I'd like to briefly explain about our activities in the Philippines. So for about 3 years, from 2012 to 2015, we implemented the EPA Re-Challenge program to provide former EPA nurses and caregivers who had returned to their home countries without passing the Japanese national exam with the opportunities to study and take the exam again. We supported about 40 former EPA candidates, and we were able to turn out dozens of successful candidates. Many of them are still working at hospitals and care facilities in Japan. Okay, please look at the slide. The photo on the right was taken in 2013. And so red circle shows the face of a woman. So this woman passed the registered nurse exam in Japan and is now working at a hospital in Hokkaido. I heard from her last year after a long time. She's now working as the nurse-in-chief of the operating room of the hospital. She told me that her son has also graduated from a nursing school in the Philippines. The reason she contacted me was that she wanted her son to work in Japan as well, and she asked me what she should do. So I introduced her to our caregiving training class for specified skills, and she enrolled her son as a student. And in 2019, so we began offering caregiving training classes to prepare students for specified skilled worker exam in collaboration with the language school in Manila. And the students live in a dormitory near the school for 6 months and study Japanese language and Japanese style nursing care. And there were about 60 students in the first term and about 50 in the second term. And there were about 40 students in the third term and about 50 in the fourth term. During the fourth semester, the city was under a lockdown due to COVID-19 pandemic. Therefore, we could no longer offer in-person classes. So since last May, we switched to remote classes and have been delivering our classes online. Currently, I'm teaching the 8th term of students. And in addition to sending out caregiving personnel, we have started the Global Leadership Training Program for medical and elderly care staff at receiving facilities in 2019. This training is designed to the participants to learn on-site and deepen cross-cultural understanding and communication. Leaders from Social Welfare Corporation and service departments for the elderly participated in the training. Although the program is currently suspended due to COVID-19 pandemic, we have had about 30 nurses and care workers come to the Philippines to receive training over the past year. Now then, let's get to the main topic. And first, let me give you an overview of elderly care education and certification in the Philippines. In the Philippines, there's a professional education and skills development agency called the Technical Education and Skills Development Authority, or TESDA. The main role of TESDA is to inspect, guide, and accredit educational institutions such as courses and schools for the acquisition of skills and techniques, and to provide skills training and issue certifications. So within the TESDA vocational education and training program, there's a professional certification course for caregivers. The certificate issued at TESDA is called the National Certificate 2, and the caregiving certification is commonly referred to as NC2 for caregiving. This is an overview of NC2 for caregiving. The NC2 for caregiving program consists of 786 hours of classroom learning, including home study, 168 hours of on-site practical training, and 32 hours of life-saving medical courses by Red Cross. After that, the candidates will take a practical skill exam at an assessment center. And those who pass the exam will become certified as care workers. And this is the curriculum for NC2 for caregiving. It is divided into 3 parts: basic competencies, which is skills, common competencies, and core competencies. The basic competencies include participation in workplace communication, work in team environment, practice career professionalism, and practice occupational health and safety procedures. Common competencies include implement and monitor infection control policies and procedures, respond effectively to difficult and challenging behavior, apply basic first aid, and maintain a high standard of interpersonal service. So core competencies include providing care for infants, children, fostering intellectual, emotional, and physical development of children with special needs, and providing care for the elderly and people with special needs. Assistance in daily living also includes cleaning living and dining areas, washing and ironing clothes, and preparing meals. So one notable difference from the Japanese care worker certification is that it includes care for infants and young children, as well as the elderly and physically challenged. And please take a look. And NC2 for caregiving is a qualification that combines an elderly care and childcare work. However, since it is not a national certification like that in Japan, it does not have the same specialization as the national certification holders in Japan. My own feeling is that the NC2 for caregiving qualification in the Philippines is somewhere between Japan's initial training or the first comer training and the practitioner's training. So, what exactly is caregiving in the Philippines? We interviewed a TESDA certified caregiving trainer. We did the interview in March in 2020 in Manila. And so, as I said earlier, and I also teach caregiving in Filipinos. However, since we are dealing with the same people in different countries, there's not much difference in the technical aspects for caregiving. So what is important is what kind of philosophy is behind it. And I asked the Filipino caregiving instructor about this point. In the Philippines, the following are the priorities about philosophy in caregiving training. Number one, to maintain dignity for a person with disease and disability. Two, be compassionate to a care receiver as well as your family. Three, to manage your feeling and be patient, even if a caregiver behaves offensively or an employer forces you to work for long hours. 4. To work hard. 5. To comprehend how a care receiver feels and provide care service from their standpoint. 6. Be flexible and deal with any circumstances and situation. So, what's interesting about this is that it doesn't look at the work of caregiving from the perspective of welfare, as in the case in Japan, but rather as workers, especially those who work under very harsh conditions overseas. So, from this point of view, the philosophy of what caregivers should be is laid out in the Philippines. Now, here is a bullet point summary of the differences in the philosophy of care between Japan and the Philippines. In both Japan and the Philippines, the first thing that comes to mind is caregiving that maintains dignity in English. The first thing I teach in my classes is caregiving with dignity. So we are in agreement here. Secondly, well, in Japan, assisting independent daily life of care receivers is important philosophy. In the Philippines, we place importance on compassionate care for the elderly in a family-like manner. To put it simply, it is the kind of care that does everything for you. This may be influenced by the religious views in the Philippines. The way of thinking is very different between Japan and the Philippines. The third point is also very different. While the Japanese elderly care emphasizes the importance of preparing the living environment surrounding the care receiver, in the case of the Philippines, the emphasis is solely on the right way to be a care worker. Indeed, if you think about working abroad, it is difficult for caregivers to adjust to the different living environment and culture of each country. So in fact, the caregivers are strongly required to be flexible and adapt to the living environment and different cultures. So my impression is that in Japan, care work is sublimated from a mere occupation to a profession and as a profession. It is talked about from a broad perspective of providing comprehensive support to the lives of the care receivers. Whereas in the Philippines, care work is seen as a part of the occupation or more specifically as a part of migrant work. I felt that there was a big difference in the way they educate people on how they should be as care workers. Therefore, I think it is important for Japan, which will be accepting many Filipino caregivers in the future. And so in the Philippines, and care workers should endure any environment and work hard. So therefore, and so when Japan tries to accept more and more Filipino caregivers, and we need to keep in mind that the way of thinking about caregiving differs greatly between Japan and the Philippines, and to continue to educate them about the Japanese concept of caregiving. Now, and let's take a look at oral health care for the elderly in the Philippines. Since I myself do not provide direct elderly care in the Philippines, so I conducted a survey on oral care in care homes and hospitals among my caregiving class students. So 19 students cooperated to the survey. And so we ran the questionnaire online from the August 11th. First, we asked the respondents how important they consider oral hygiene care to be in caring for the elderly. As shown in the slide, all 19 respondents answered that oral care is important. So when asked why, they said providing oral care leads to a better quality of life for the elderly. If oral care is neglected, the elderly is more susceptible to infection from the mouth. They did not consider oral care as a local matter, but as an important care that affects the whole body and the whole life of the person. However, there seems to be a general lack of awareness of the importance of oral care. It seems that oral diseases are still a serious problem in the Philippines. The Department of Health in the Philippines continue to educate the public on the importance of proper oral care. Well, as you can see from the result, there seems to be a big difference in the way oral care is perceived between medical professionals and the general public, especially the poor. Next, we asked about oral exercises, which are widely practiced in elderly facilities in Japan. About half of the respondents answered yes to whether they do oral exercises before meals. The other half answered no or I don't know. And it seems that oral exercises are not so widely known compared to Japan. Next, I showed the students a video of Japanese oral exercises and asked them what they thought. All of the students gave positive feedback that they would like to introduce Japanese oral exercises into elderly facilities in the Philippines. Well, since I came to the Philippines in 2011, I have been visiting elderly care facilities in and around the capital city of Manila. Unlike in Japan, in the Philippines, care is usually provided by family members at home, and there are only a few care homes. However, the number of the elderly care facilities is gradually increasing. The reason for this is that the number of children among the wealthy family is decreasing, and they can no longer take care of the elderly at home. In the Philippines, where 10% of the population is working overseas, there's no one to take care of the elderly since all the family members are overseas and they have to use care facilities. Many of the facilities for the elderly were renovated as single-family houses that looked like shared houses with nurses and caregivers working around the clock for the care of the elderly. There were also large-scale facilities that could accommodate 30 to 40 people, but these facilities were also renovated from the former churches or schools to reduce construction costs. And according to the information from the students who cooperated in the survey, the oral care is almost the same as in Japan. Brushing with a toothbrush, gargling with a mouthwash to prevent periodontal diseases and cleaning dentures. The only difference is that in the Philippines, there is not enough coordination with outside dentists and dental hygienists. So if there's an oral problem, the nurse working at the facility calls the dentist to the facility, or the staff will accompany the care receiver to the dentist. The cost issue seems to be the reason for the lack of regular checkups. And my impression from the field survey is that there are issues in the water section environment for oral care and hygiene management of oral care utensils. In recent years, the importance of oral care in caring for the elderly has been increasingly recognized, and last year, the International Federation for Dementia Care, to which I belong, invited a dentist as a guest speaker to give a seminar on the relationship between oral care and dementia. Although it was a webinar, it was viewed not only by Filipinos in the Philippines, but also by Filipinos and English-speaking people overseas, numbering about 500 people. The audience include healthcare professionals such as dentists, nurses, and caregivers, as well as non-healthcare professionals who are caring for family members at home. Well, these are some of the slides that were used in the presentation. We also talked about the relationship between oral care and aging and the progression of dementia. As I mentioned earlier, there seems to be a general lack of awareness about the importance of oral care. However, I had the impression that the medical professionals and those who are actually involved in family care are becoming more aware of it and are becoming more specialized. So I felt that there is a potential for the transfer of Japanese excellent oral care products and technologies overseas. So that's my presentation, and thank you very much for your kind attention.
Mr. Fukui, thank you very much for your presentation. Now I'd like to invite Ms. Zonti Tufon from the Tokyo Health Science University. So she will also present her presentation in video. She's also participating in this event live, so you can ask questions to her as well. Ms. Fon, please. Good afternoon, everyone. I'm Fon and worked as a nurse in Japan for 3 years through second batch of the EPA program. I suppose you often hear that the way nursing is provided is different between Vietnam and Japan, but do you know how different? Today, I will walk you through the 5 aspects where the differences in nursing lies between the two countries. Very nice to meet you. Let's start with the education system. In both Vietnam and Japan, nurses are educated in 2, 3, and 4 years programs according to the level of qualifications. In Vietnam, however, the intermediate level of education is to be abolished in this year, 2021. And next is about the nursing certification. In Japan, you can become a licensed practical nurse or registered nurse by taking practical nurse exam or the national exam. But in Vietnam, there is no nursing exam and no nursing license. In other words, according to Vietnam's law on diagnosis and treatment, the following professions are eligible to obtain a medical certificate. So, looking at this list, so when you look at this way, in Japan, the medical license and the nursing license are 2 different things, but in Vietnam, they are supposed to have the same certificate. There are 3 steps to get a medical certificate. There is a graduation exam in the second semester of your final year at school, and then after graduation, you have to be on training in a clinical setting for 9 months to obtain your medical profession certificate. However, after graduation, you may be able to find a job even if you don't have a medical certificate yet. You can obtain your certificate of medical profession by working at a medical institution for 9 consecutive months. The third is the different timing from which you can practice your skills. In Japan, you can perform invasive care only after you have a nursing license, but in Vietnam, you can go for practical training even when you are a student and perform invasive care directly on the patient under the supervision of nurses in the hospital wards. Next, let us compare what nurses do in both countries. Nurses are tasked with assisting with medical treatment and performing medical procedures. But in Japan, nurses are also responsible for assisting patients with daily living as well. In Vietnam, it is common for family members to take care of the patient's personal needs. For example, family members are responsible for changing the patient's diapers and guiding the patients to the bathroom for toileting and assisting with meals. And accounting work in Vietnam is done by nurses. However, due to the coronavirus, one hospital is no longer able to allow family members to attend to the hospitalized patients to take care of them. So the personal care is now left to the nurses. This has increased the burden on the nurses due to the personnel shortage. The patients are sometimes reluctant to ask nurses to guide them to their bathroom, as the nurses seem unwilling to do so. However, recently, nurses in international hospitals and highly medically equipped hospitals have started to provide all the assistance to the patients in daily life. So let's look at an example of what care is provided in the case of a bed sore for comparison. In Japan, those who can roll over on the bed by themselves use pressure dispersion mattress, while those who cannot use air mattresses or air mattress a hybrid type. In Vietnam, bed mattresses are generally used and air mattresses are used if there is a risk of developing bed sore. Please refer to these photos to see the differences in the type of mattress mentioned before. When erythema, periosis, blisters, and erosions appear in Japan, transparent dressing agents are used for protection, but in Vietnam, it is covered with gauze. Japanese people have a custom of taking a bath in a bathtub, and even patients who are bedridden or on respirators can take a bath during hospitalization. Vietnamese people do not have the habit of taking a bath, so patients who can stand on their own take a shower by themselves. Patients who are bedridden or use a respirator are wiped in bed by family members or nurses. For the evaluation of the bed sore progress, the design R scale is generally used in Japan as a standard, but in Vietnam, the recording format differs from hospital to hospital, and there is no standardized scale yet. Looking at the above 5 points, can we compare the differences between nursing practices in Japan and Vietnam? It is still in the process of development at this point, but I believe that as time goes on, Vietnam will shift to complete nursing care as like in Japan. This concludes my presentation. Thank you very much for your attention.
Thank you very much, Ms. Fon. Now, this concludes all the presentations for the section 2 and the Japanese caregiving viewed from Asia. And after this,